Ladies and gentlemen, good afternoon. My name is Timothy Steiner. I must say I like this concept of having the chairman sit in armchairs on the platform. It's a much nicer way of doing it than the stuffy way we have in Europe of sitting formally at a table. So I think we must import this system to European meetings. The pyramidal people are not back yet, but thinking that we have lunch scheduled at 4 o'clock, I think, well, we've been told that we should start. So we have, in theory, 9 presentations in this 90-minute session. No, it's actually 10 presentations, so that's 9 minutes each. I hope the speakers will keep to time, and if you do, we will have questions after each session. And if you don't keep to time, the probability is that 1 or 2 speakers will not arrive, so we may be able to rescue the situation. So we will start, and I ask Shireen El-Musli to give the first presentation, Quantitative D-dimer level and anticoagulant therapy in idiopathic intracranial hypertension. Thank you.
Good evening. I would like to thank first the organizing committee, on top of them Professor Usama Abdelghani and my Assistant Professor Ramiz Reda for giving me the opportunity to participate with you today. I will present a master work in Fayoum University under the title Quantitative D-dimer level and anticoagulant therapy in idiopathic intracranial hypertension. As we all know, it is a syndrome characterized by elevated intracranial pressure of unknown etiology, and it predominantly affects the obese women. Usually, the patients present with headache, visual dysfunction, and pulsatile tinnitus. It is still, the pathophysiology still remains obscure, and there are many proposed mechanisms such as increased brain water content, excessive CSF production, reduced absorption, increased cerebral venous pressure. It was noticed that the increased venous pressure may occur as a result of bilateral transverse sinus stenosis, endocrinal changes, hypercoagulable state, and specific medications. And a recent study showed that there is a prosthrombotic state with an elevated D-dimer level in obese IIH patients. So we aimed in this study to evaluate the level of D-dimer level in IIH patients and to see if we can use the anticoagulation added to the routine treatment in those patients. This is a prospective case control study which was carried out in the neurology department of Fayoum University Hospitals. We recruited 24 consecutive IIH patients of both sexes, and they were all fulfilling the modified Dandy criteria. We excluded patients with disturbed conscious level, focal neurological signs, CVS, seizures, cerebral venous sinus thrombosis, septic sinus thrombosis, granuloma, infection, head trauma or surgery, and on the systemic level, cases of DVT, DIC, pulmonary embolism, malignancy, and acute nephrotic syndrome, and finally, pregnant females or those who terminated their pregnancy in the last 4 weeks. The patients were divided randomly into 2 groups. Group 1 received acetazolamide with low molecular weight heparin in a prophylactic dose for 2 weeks, and Group 2 received acetazolamide only. And we have 24 age, sex, and basal metabolic index matched healthy volunteers, which were included as a control group. And we measures for the patients and the controls the serum quantitative D-dimer using the ELISA technique. For the assessment of the patients, for the headache, we used the headache impact test score. For the ophthalmological assessment, we made a fundus examination using the Friesen classification, visual acuity using the Snellen chart, and the results were converted into logarithm of minimum angle of resolution. visual field assessment using the automated perimetry, and it measured the visual field mean deviation, and finally the visual evoked potentials to measure the P100 latency and amplitude. We evaluated the patients at the first visit as a baseline, then we followed them after 1 and 6 months. And here are the demographic data of the patients and the controls, and we can see that they are matching and there was no statistically significant difference between them. All of our patients were presented with headache and papilledema, and we found that the mean D-dimer level was higher in patients compared to control with a statistical significance. As regards the HIT score, we found that most of the patients were presented at the baseline with substantial impact to severe impact, and they improved over the next 6 months, and the majority of them were in the little or impact or some impact at the end of the study. When we compared group 1 to group 2, we found at the level of the HIT6 test that it improved more in group 2 after 6 months. For the visual assessment regarding the fundus examination, it improved in both groups and more in group 1. The same for the visual acuity, it improved after 6 months for both groups and more in group 1. The same for the visual field assessment. The visual field improved after 6 months in both groups, more in group 1. And finally, also for the VEP, the P100 latency decreased and the P100 amplitude increased after 6 months, and the improvement was more in group 1. From these results, we can say that there is a prosthrombotic state in these patients, and because they have a high level of quantitative D-dimer. And those patients on the visual assessment, they improved after 6 months, especially those who received the anticoagulation. And we speculate that there might be an underlying undetected microthrombi which impeded the CSF drainage. And finally, we recommend a routine screening for the D-dimer to find an imaging procedure that can recognize this microthrombi, and further studies on a larger scale using different regimens of anticoagulation to see if we can establish it as a treatment for those patients. Finally, this is, as I said, a master degree provided by Amani Hamdi, and it was under supervision of Professor Hala Shaheen and Professor Said Sobhi and me. And thank you all for your attendance.
Thank you for exemplary timekeeping, showing the way for the others. There is time for questions. Yes.
Thanks for this nice presentation about the transverse sinus pathology in idiopathic intracranial hypertension. The pathology is stenosis of the transverse sinus, or it is occlusion by a thrombus?
For those patients, there was no thrombosis or stenosis by MRV.
Anybody else? Okay, thank you very much. Oh, is there, sorry, there's one there.
About using LM low molecular weight heparin, 2 weeks only?
Yes, because there are no previous studies which used this kind of treatment. So we just try to give a small dose and see what will happen.
No oral after that?
No oral, no.
Okay,
just
Okay, I don't see any more, so thank you very much indeed. And we go to the next presentation by Shireen Ahmed, Sleep and Psychiatric Abnormalities in School-Aged Children with Migraine.
Sleep and psychiatric abnormalities in school-age children with migraine. Migraine is a common primary headache characterized by complex neurovascular disturbance and brain sensory hyperexcitability, leading to recurrent attacks of severe throbbing headache, often unilateral, lasting 4 to 72 hours, accompanied by nausea, vomiting, and extreme sensitivity to light and sound. Migraine is common in children and adolescents. By age 10, the prevalence of migraine in children is approximately 5%, and it increases further over the course of adolescence. Prior to puberty, migraine affects boys and girls equally. By late adolescence, migraine affects more girls than boys. Migraine duration in children can be shorter, particularly in children younger than 7 years of age. In the International Classification of Headache, the lower margin of duration for untreated or unsuccessfully treated attack in children is 2 hours versus 4 in adults. The majority, more than 80%, report bilateral migraine headache. International Headache Society had classified migraine headache to migraine with aura, migraine without aura, chronic migraine, complicated migraine, and episodic syndromes associated with migraine. There is a reciprocal relationship between migraine and the psychiatric state due to sharing the same etiological mechanisms. The most common comorbid psychiatric disorder include separation anxiety, school phobia, adjustment disorder, ADHD, and conduct disorder. There is a strong association between migraine and sleep disturbances due to sharing the same neuropeptide abnormality, including serotonin, dopamine, and melatonin. Sleep deprivation as well as hypersomnolence promote headache attack, while migraine sufferers often experience insufficient sleep, difficulty falling asleep, parasomnia, and excessive daytime sleepiness. The aim of this work was to study the existence and type of sleep and psychiatric disorder in school-aged children with migraine. The present study was a prospective one conducted in 40 school-aged children with migraine and 20 age and sex-matched healthy control subjects. Migraine was diagnosed according to the International Classification of Headache Disorder. Included subjects were submitted to thorough history and neurological examination. Brain image, headache disability were assessed using pediatric migraine disability assessment scale. Psychiatric assessment were done using KSAD, present and lifetime, and the child behavior checklist. Sleep evaluation using Epworth sleepiness scale, Pittsburgh Sleep Quality Index, and one-night polysomnogram. Regarding our result, regarding migraine subtypes, 65% had episodic migraine without aura, 27 had episodic migraine with aura, 5 had visual, and 6 had abdominal aura, and 7 had chronic migraine. There was increased anxious depressed symptom among the child with migraine, which was positively correlated with disability. Children with migraine often experience decreased sleep duration and interrupted sleep with difficulty in sleep maintenance. This figure shows comparison between both groups regarding the child behavior check test. There was a significant increase in anxious depressed and withdrawal depressed symptom in a migrainous patient. This figure shows comparison between two studied groups regarding the sleep data. There was significant increase in Epworth sleepiness scale and the Pittsburgh Sleep Quality Index. Regarding the polysomnographic data, there was significant decrease in total sleep time and decreased sleep efficiency. There was positive correlation between anxious depressed symptom and the pediatric migraine disability assessment scale. There was negative correlation between sleep efficiency and the pediatric migraine disability scale. This hypnogram shows decreased total sleep time, prolonged sleep latency, increased N3 stage, and interrupted sleep. In our study, we concluded that pediatric migraine tends to be shorter in duration. One possibility might be that children are more likely to take naps, and sleep seems to be helpful in terminating migraine attack. Pediatric migraine is often associated with sleep and psychiatric abnormalities, which must be probably managed to reduce school absenteeism and healthcare costs. Thank you.
Thank you very much. You kept very nicely to time, but you presented so much data that I think it was quite difficult to keep up with it. Does anybody have questions?
Hi, thank you. There's a lot of data. I'm sorry if I missed it. Is there a correlation between, or relationship between frequency of attack and sleep disturbance? To try and get at some level at the question of whether the migraine drives a sleep problem or the sleep problem drives migraine.
Yes, there was a significant correlation between attack and severity.
Thanks.
Does anybody else have a question? Yes.
Thank you for the very good presentation. Complete to this question, if there is a relation between the timing of the attack and the sleep disturbance, if the child has attack before he's going to sleep, this affects the sleep pattern or not?
No.
Or you don't did this
No. No.
You don't? This is a very good point to be highlighted. Thank you.
Anybody else? Okay, thank you very much indeed. So we now go to the third speaker, Aya Farouk, efficacy of repetitive TMS in treatment of, I'm not quite sure what that is, chronic daily headache. Primary chronic daily headache, sorry.
Bismillahirrahmanirrahim. Efficacy of repetitive transcranial magnetic stimulation in the treatment of primary chronic daily headache. Cortical plasticity is the reorganization of the brain to improve the function of its networks. It's not limited to the cortex. It spreads across the cortical circuits at the cortical and the corticothalamic pathways. Transcranial magnetic stimulation is a non-invasive tool for the electrical stimulation of the neural tissue. It uses a rapidly changing magnetic field to induce weak electrical currents through pulses. Generally, it reaches no more than 5 centimeters into the brain. The coil is held above the head, and pulses penetrate the skin and the skull. This causes long-term changes in the synapses, involving long-term potentiation following brief high-frequency stimulation, or long-term depression following brief low-frequency stimulation. Also, there is sensitization of new synapses through transcription factors of target genes. As regards chronic daily headache, it is headaches present at least 15 days per month for at least 3 months for at least 4 hours per day untreated. Chronic tension headache type is the most prevalent, costly form of headache. It represents approximately 80% of all headache diagnoses. Also, migraine is a common neurological disorder. It is reported that 43% of women and 18% of men suffer from migraine at some point of their lives. The aim of this work was to open a new treatment strategy, thus improving the quality of life of such patients. Stimulation of the dorsolateral prefrontal cortex might exert an inhibitory effect on pain perception, either by activation the supraspinal pathways or by resetting or reducing the frontolimbic dysfunction seen in chronic painful conditions as chronic tension headache and chronic migraine. Also, it was reported that the high-frequency repetitive transcranial magnetic stimulation over the frontal cortex increases the basal low plasma beta endorphin levels in the migrainous patients, which was associated with improvement of migraine. Transcranial magnetic stimulation was able to inhibit the cortical spreading depression in animal models experiments, thereby modulating the intracortical excitability via a paradoxical effect, suggesting potential therapeutic implications, especially in migraine with aura attacks. This is a case-control study carried out on 27 patients having chronic daily headache according to the International Headache Society criteria. They were divided into two groups. So the study group included 16 patients who received real 5 Hertz repetitive transcranial magnetic stimulation, and control group included 11 patients who received sham repetitive transcranial magnetic stimulation. The inclusion criteria: the patients with chronic daily headache, chronic tension type, and chronic migraine, having daily or near daily more than 15 days per month severe headache, poor response to medication for at least 3 months, normal CT or MRI of the brain, the exclusion criteria, other types of primary headache and secondary causes of headache, epilepsy or family history of epilepsy, pregnant females, patients with pacemaker, intracranial metallic objects, or artificial metallic tooth. The assessment procedures: clinical assessment, headache assessment, and routine labs radiological assessment. The headache assessment, it was done after the first visit. The patients were given diary to rate the headache parameters before starting and after finishing the treatment sessions. The scale included the duration of illness, frequency of headache attacks per month, pain intensity measured on a 4-point scale, 0, 1, 2, 3, and the headache index, which is frequency multiplied by intensity. Repetitive transcranial magnetic stimulation was applied at the Clinical Neurophysiology Unit, Qasr Al Aini, Cairo University. After calculating the motor threshold using a single pulse stimulation over the prime motor cortex at a hot point of the first dorsal interosseous muscle. The two groups studied: the study group, which is the real group, and the control group is the sham group. Both received 12 sessions of high-frequency repetitive transcranial magnetic stimulation every other day for successive weeks. 5 Hertz, 90% of the motor threshold intensity over the left dorsolateral prefrontal cortex. And as you can see here, the first one, the real study group, the butterfly, the 8-figure butterfly stimulator was held directly over the head, while the sham group, it was held perpendicular to receive the sensation, but there is no or minimal magnetic stimulation received. Both groups were matched as regard age, gender, duration of illness, and no significant difference between the study and control groups as regard the headache intensity, frequency, or index. As regard the comparison of the headache frequency and index before and after treatment within the control group, there was no significant difference, with the percentage of improvement was about 7.9%. The patient group's comparison of headache frequency and index before and after treatment showed high significant difference. The percentage of improvement was 94.5%, which indicates a significant improvement. Comparison of the headache intensity before and after treatment within the study and control group. The study group showed high significant difference, while the control group showed non-significant difference. Also, comparison of the post-treatment headache parameters between the study and control group showed high significant difference as regard headache frequency, intensity, and an index. There was no significant correlation detected between the response to the repetitive transcranial magnetic stimulation with the age of the patient, duration of illness, headache frequency, or intensity. Conclusion, we can conclude that high-frequency repetitive transcranial magnetic stimulation is beneficial in improving the patients with chronic tension headache and chronic migraine. So it is recommended to consider high-frequency repetitive transcranial magnetic stimulation as a treatment option for patients with primary chronic daily headache, especially those poorly controlled with medication. Thank you.
Thank you very much also for keeping to time. I'd just like to pick you up on one point. It doesn't detract from everything else you said, but the International Classification of Headache Disorders has never, in any of its editions, used the term chronic daily headache. So you cannot really say chronic daily headache as defined by IHS. If you stick to the terms migraine and chronic tension type headache, you will not. Anybody have questions? Yes, please.
Thank you, Dr. Aya. I have a question, please, about how many times did you recommend the sessions of the repetitive transcranial Doppler magnetic stimulation? Daily, week after week, 3 sessions per week?
It was carried day after day, except the weekends, for 4 weeks.
For how long?
For 4 weeks.
4 weeks.
Yes.
And after this, it is enough for the patients, or repeated another sessions after 2 or 3 months?
We didn't do follow-up. We only did for 4 weeks. Okay. We excluded pregnant. Because transcranial magnetic stimulation is still questionable about, we don't trust it for pregnant. I think it's, we did until 4 weeks.
But you don't know.
We didn't do follow-up.
This is very important because
yes.
A patient will not live on TMS.
On repeated, yes.
Okay.
Yes.
You said that it is efficacious in both chronic tension headache and the chronic migraine, didn't you?
Afande?
It was effective in
yes.
both chronic tension headache and
chronic migraine. Yes, yes.
So why could it be effective in both of them while the mechanisms
are different?
Are quite different.
Because
why? What's your explanation? I mean,
our explanation is the stimulation of the pain control center of the dorsolateral prefrontal cortex. It controls chronic pain and
unspecific. You mean?
Unspecific.
About using TMS in children, is it safe?
Children, I didn't do in children, but I think, I think we did after adolescence. I don't know if we worked. We didn't try in children.
Yeah.
Please. Does it depend on the intensity of our TMS? Does it depend on the intensity of TMS?
What?
Which intensity?
90% above the motor threshold.
Okay, thank you.
Yeah, just one more question. Why did you choose high frequency TMS and not inhibitory low frequency?
Because there were many studies before compared the high frequency and low frequency, and the high frequency did give a better response, and we tried to do it to confirm.
Okay. You think maybe the response is related to depression or anxiety relief? associated with the dorsolateral prefrontal stimulation. Because it relieved anxiety or depression, I think.
Yes, yes, but we didn't, our own scope in this paper was for the pain and the migraine and the diary of pain. We didn't assess any other parameters.
Thank you.
Okay, thank you very much indeed. The next two speakers I think are not here, so we go now to Mena who will speak on utility of orbital ultrasound in headache of intracranial hypertension, the KUNU experience.
Bismillah ar-Rahman ar-Rahim. Dear organizers, dear Mr. Chairman, thanks for accepting our work, utility of orbital ultrasound in headache of intracranial hypertension, CU experience. This is our trigger case. A 32-year female has diagnosed as BESIT, fully anticoagulated, presented with severe intracranial hypertension. Fundus examination was not conclusive because the posterior adhesion and the cataract. So we try to, we know all that increased intracranial pressure transmitted to the subarachnoid space surrounding the optic nerve, leading to optic nerve sheath expansion. So we found many literature about the normal cutoff value, but in Egyptian we didn't found. So we try to design our study to answer these two questions. What is the sonographic cutoff value of optic nerve sheath dimension in Egyptian patient with IIH according to modified Denti criteria? The second question, can we monitor the ICP changes in this patient with the optic nerve sheath dimension, papillary height, or ophthalmic vessel hemodynamics? We designed our study as a case control study on 124 females, age matched, 99 patients diagnosed with modified Denti criteria, and 35 normal healthy subjects. We do for all participants medical neurological assessment, especially body mass index, ophthalmological evaluation, imaging to exclude any secondary causes, and ultrasound with a linear probe 7 to 13 megahertz with a LARA principle as low as reasonably achievable for avoiding any damage for lens or retina. And all patients performed lumbar puncture after the initial study of ultrasound. And our method, we just leave the patient supine, head elevated 20 degrees. The probe put gently on the lateral aspect with the eye closed, and gently, please gently. And we measure as like this figure, as I show, we measure. We saw a hypoechoic optic nerve by the ultrasound, surrounded by hyperechoic sheath, and we measure 3 millimeters from the posterior border of the globe, and then the gray line demonstrates the optic nerve diameter, and the white line is the optic nerve sheath diameter, and we, from this measurement, we calculate, we measure twice for each eye, and then taking the mean of both eyes, optic nerve sheath dimension and the optic nerve sheath dimension ratio. And as we here, there is the demographic and of the participant just increasing body mass index between IIH group, which is expected. And as a result of when comparing the optic nerve sheath, there is significant increasing in the papillodemic eyes. However, no change in the ratio significantly. And we design a ROC curve to determine the cut-off optic nerve sheath dimension, which can predict increased intracranial pressure, and the area under the curve 0.85 with sensitivity 73% and specificity 21%. With cut off 6.1 millimeters. So we answer the first question according to the Egyptian female patient with IIH with more than 6.1 millimeter considered increased intracranial pressure. And this is an example of in our patient. The second question, can we monitor the increasing ICB or decreasing after medication? We do a prospective single center case control on 24 patients compared by control. We do this all parameter in the first visit initially before lumbar puncture and 1 week and 4 weeks after intervention medical treatment. And we found that there is significant reduction in the sheath and also in the papillary elevation. However, the ophthalmic hemodynamically is not significant. And also, we found there is a significant correlation between the papillary elevation and increasing cerebrospinal fluid opening pressure. So we can conclude that by the two research, sonographic optic nerve sheath dimension offer bedside screening indicator of elevated intracranial pressure in IIH patient, and we estimate the cutoff between Egyptian 6.1 millimeter and transcranial orbital sonography can helpful with monitoring the papillary elevation to follow up ICB changes at least after 1 month following treatment initiation. However, the disease insignificantly influences ophthalmic vessel hemodynamic. And to the best of our knowledge, no publication regarding optic nerve sheath dimension measured in IIH patient from Middle Eastern countries. And this is a good chance to invite anyone who is interested for that to do a multi-center study. And finally, I thank again the organizer for this fantastic meeting and thank our team in Cairo University Neurosomnology Unit. Thank you.
Thank you very much. If there is any relation between optic sheath with imaging?
With imaging? We didn't do orbital MRI. We didn't orbital MRI, the measuring of orbital, the ultrasound.
We need this relation.
Yeah.
Because it will give us another causes or another possibility to other causes.
Yeah, our aim can for a simplistic way bedside test to monitor the ICB with difficulty in doing lumbar puncture or successive lumbar puncture.
One question.
What is the benefit or advantage of optic nerve sheath ultrasound measurement over the fundus examination?
The fundus examination can...
By the ophthalmoscope, the regular ophthalmoscope.
As I mentioned in the first trigger case, such case was on fully anticoagulant and has an opacity cannot reaching the fundus. This is number one. Number two.
So it is normal fundus examination? The case have normal fundus examination?
We cannot show the fundus already. Patient coming by increased intracranial tension with normal MRI, MRV, and the fundus cannot be seen by the ophthalmologist due to the opacity of the lenses. Actually, we didn't examine the patient with opening pressure. Any patient, we examine optic nerve sheath dimension and doing the lumbar puncture. If the lumbar puncture, the opening pressure below 25, we exclude it from the study. So we cannot answer. Sorry? Yes, yes, yes.
Hello, Nermeen. Did you consider these changes as specific to the increased intracranial hypertension?
Specificity take 92%.
This is very high as the changes you considered in your study is similar to the changes detected in cases of neuromyelitis optica or optic neuritis.
The condition in neuromyelitis optica is so different because there is the papillitis more than papilledema.
But there is increase in the thickness of the optic nerve sheath diameter when
Some-
we did ultrasound for those patients.
For sure, but we focusing on the papilledema due to the damage that occurring in increased intracranial blood pressure, intracranial pressure. However, neuromyelitis optica, there is no increase in intracranial pressure. We just inflammation may be increasing in the diameter, but in our study we focusing on increased intracranial pressure. We documented increased intracranial pressure before we take this analysis.
Yes, I know. I just said this is not specific changes to this disease.
No.
No. Yes.
No.
Yeah, you can be detected in any other
the
diseases.
patient is fulfilling the criteria with modified identity criteria, clinical also.
Yes, thank you.
Thank you, Doctor. We shift to Dr. Ghada Sayed Abdelaziz from Egypt to talk about volumetric brain changes in migraine.
I'd like to thank the scientific committee for giving me this opportunity to talk about the volumetric brain changes in migraine. Migraine is a common neurologic disorder characterized by paroxysmal attacks of unilateral throbbing headache and autonomic nervous system dysfunction. About 1/3 of migraineurs experience transient neurologic symptoms known as auras, which characterize a variant known as migraine with aura. Chronic migraine typically evolves from episodic migraine over months to years in susceptible individuals. Headaches increase in frequency over time, becoming less intense but more disabling and less responsive to treatment. Chronic migraine affects 1 to 2% of the general population and about 8% of patients with migraine. It usually develops from episodic migraine at an annual conversion rate of about 3%. Traditionally, migraine has been considered a benign disorder without long-term consequences for the brain. Neurologists usually image patients with migraine to exclude secondary causes of headache. Certain structural and functional differences in various brain regions in migraine patients have been highlighted in recent years by using advanced neuroimaging techniques. MRI brain-based volumetry is increasingly being used in the clinical setting to assess brain volume changes from structural MR images in a range of neurologic conditions. Measures of brain volumes have been shown to be valid biomarkers for the clinical state and progression by offering high reliability and robust inferences on the underlying disease-related mechanisms. Voxel-based morphometry is a fully automated, highly sensitive technique to detect focal gray and white matter abnormalities in the brain. The aim of this study, the goal was to investigate the presence of volumetric brain changes in a group of Egyptian patients with migraine in comparison to healthy controls. We further analyzed the data of the patients in order to look for structural brain differences in migraine subgroups, and we evaluated correlations with the clinical characteristics of the disease. Subjects and methods. 25 migraine patients, 18 females and 7 males, were recruited from Neurology Outpatient Clinic of Zahra University Hospital. 18 patients fulfilled the International Classification of Headache Disorders criteria for migraine without aura, and 7 patients for migraine with aura. We further divided the patients into 2 subgroups based on the monthly attack rate: episodic migraine patients with 14 patients and chronic migraine 11 patients. The patients included in the study had no history of chronic or active systemic diseases or major psychiatric disorders except for depression, or any neurological diseases except for migraine, and the age ranged from 18 to 40 years. Also, another 25 healthy individuals matched for age and gender were used as control group. All participants were subjected to the following: full history taking and complete general and neurological examination, standardized headache assessment form for the patients, migraine disability assessment scale, big depression inventory score, and the brief cognitive assessment tool, and the MRI, high resolution images MRI. MRI images were processed using automated segmentation method free server. This is an example for the morphovolumetric analysis through free server software for the right cortical thickness. The result was as this table shows the clinical data of the patient's group. This is a comparison between patient's group and control group as regards the big depression inventory score and the brief cognitive assessment tool. Results of brain volumetry. Comparison between patients and control groups as regards total brain volumetry and cortical thickness parameter by free server. It shows significant reduction in the total brain volume, cortex volume, cerebral white matter volume, and the total gray volume in the patients with migraine in comparison to control group. And this figure shows that there is significant difference between the patient group and control group as regards the total brain volume and the total gray matter volume. Comparison between patient's group and control group as regards the segmental brain volume and thickness parameter. It shows significant reduction in the volume of brain stem, left cerebellum and right cerebellum, and left and right basal ganglia, left thalamic volume, left hippocampus, and left amygdala volume in patients with migraine. This is a significant difference between patient and control as regards the brain stem volume. And this is a significant difference between the patient and the control as regards the left cerebellar and right cerebellar volume. When we differentiate between migraine with aura and migraine without aura, we found only significant difference as regards the left cerebellar volume, significant reduction in migraine with aura patients. After division of the patients into chronic and episodic migraine, there was significant difference as regards the total brain volume, cortex volume, and total gray matter volume in patients with chronic migraine in comparison to episodic migraine. As regards segmental brain volume, there was significant reduction in patients with chronic migraine as regards the cerebellum on the right and on the left side, and the frontal lobe thickness on the right side and left side in comparison to episodic migraine. When we do the correlations with the parameter, with the clinical characteristics of the disease, there is significant correlation between frequency of attacks and right frontal pole thickness, and also between frequency of attacks and the left lateral orbitofrontal thickness. Also, there is negative significant correlation between duration of the disease and left medial orbitofrontal thickness, and negative significant correlation between the duration of the disease and right caudal middle frontal thickness. In conclusion, our study shows that in patients with migraine, there is a significant gray matter reduction in several brain areas that belong to the central brain network, specifically those involved in processing of the affective and cognitive component of pain. But additional longitudinal, functional, and structural MRI studies with higher samples of patients are needed to elucidate the mechanisms underlying these gray matter abnormalities. In comparison to episodic migraine, those with chronic migraine suffering more depression, cognitive impairment, migraine-related disability, and reduction in total and segmental brain volume. These data support the results of previous studies suggesting that migraine may be considered a progressive brain disorder. Take-home message. Migraine is not just an episodic disorder, but may be a chronic progressive disorder and may have cumulative effects on the brain in terms of both structure and function. Successful treatment of migraine patients before the chronification of symptoms might prevent brain atrophy and decrease the burden of the disease on cognitive functions and the quality of life in migraine patients. Thank you.
Thank you, Dr. Ghada, for nice presentation. Because of time. One question.
Thank you so much for your very nice lecture. But I want to ask first, the age of your patients was
from 18 to 40 years.
18 to 40? Okay. What about other risk factors? You are looking for other risk factors, hypertension, diabetes, whatsoever, like some sort of other risk factors which could explain what did you find?
The other risk factors were excluded, exclusion criteria. Patients have only migraine.
Only migraine? And the cause is reduced volume? Only migraine and young
migraine
age?
with depression only. Migraine or migraine with depression only. No hypertension or diabetes or other systemic disease.
Regarding, you find a correlation with the frequency and duration. That's okay? Which frequency? You divided your patient to groups, right? 15 days a month?
No,
right? Less than 15 and more than 15, right? Which group showed this volumetric reduction?
Correlations was with the patient group frequency of attacks in the patient group as a whole.
As a whole. Thank you.
We go back for Dr. Yard Zenipa from Ethiopia. We will talk about traditional understanding of migraine. Welcome.
Okay, thank you. Sorry for the late inconvenience. So I'll proceed with the traditional understanding of migraine from the traditional, from the early history to the modern centuries. So in the ancient world, headache was thought to be found since the creation of human beings. Thought the Italian scientist Masio, the artist who paint in Florence, Italy, shows the depiction that Adam hold or grab his head as at the time when they were expelled from the Eden. So that could be the first sign of a headache. Who is not sure about that. But headache was thought to affect humankind from the dawn of civilization, where Neolithic human skulls shows signs of trepanation, where on the Stone Age there are instruments to make a trepanation on the skull that thought to be as a treatment for the headache by the time, and signs of trepanation, patients survived that moment, and signs of healing on the skull on alive patients were found by the Stone Age. So this illustration shows a procedure of trepanation where a patient undergo a trepanned procedure in the room where there is no anesthesia, where there is no antiseptic procedures were used by the time. So in ancient Egypt, they know about headache, and there were evidence shows there were written evidence on papyrus where headache prescriptions written. And this was the Ebers Papyrus, who was a professor of Egyptology from Leipzig, who identified and translated the papyrus, and which was dated 1200 BC, and they were identified between the legs of the mummies by the time where they were thought to be written for them, and said to be a medical document from 2500 BC, and they describe the basic migraine, neuralgia, and shooting head pain. And on this illustration, Dr. John Edmonds tried to show us a headache sufferer who presented with a headache, and they tried to put a crocodile made of clay, having some kind of grain in his mouth, and tied up to his head with a string of fabrics with the name of the goddess on the head. So they thought this could be the first medication for a migraine at the time. So later on, Hippocrates, who have know-how about Egyptian medicine, described first time the visual symptoms of migraine, where the visual auras, laterality, and the vomiting associated with the headache. So he explained it as a shining light, usually on the right eye, followed by violent pains that begin on the right temple, then involving all the head and neck. where vomiting able to divert the pain and render it moderately. And he also believes that other type of headaches could be triggered by exercise and intercourse, where they resulted from a vapor arising from the stomach to the head. Later on, Cornelius, he believed migraine could be induced by drinking wine or exposing to too hot or too cold weather, or hot of a fire or a sun. The later Galen distinguished migraine from other headaches and coined the term hemicrania, which means unilateral headache. So he described it as a painful disorder affecting approximately 1/2 of the head, and which extends along the length of the longitudinal suture caused by ascent of vapors, either excess in amount from the stomach or too hot or too cold. And this hemicrania was later translated to a migraine in Old English Dictionary and a migraine in French. Aretas, who was born in Cappadocia, the current Turkey, in 80 AD, described migraine as a description that there is a flee the light, the darkness soothes their disease, nor can they be ready to look up or hear anything agreeable. Their sense of smell is vitiated, neither does anything agreeable to smell delight them, and they have also an aversion to fetid things. The patient, moreover, are weary of life and they wish to die. So later on in the centuries, in 12th century, Abbas Hildegard of Bingen described her visual phenomena as her visual aura phenomena as, I saw a great star, most splendid and beautiful, when it has an exceeding multitude of falling stars, in which the star followed southwards, and suddenly they were annihilated, being turned into black holes and cast into the abyss, so that I couldn't see them no more. So later on, Thomas Willis described a severe headache on a woman with a beautiful description, and later the Swiss physician Wefer noted the alteration of migraine from one side to the other, sometimes attributing this to the relaxations of the vessels. Later on, Tissot commented, a focus of irritation is formed little by little in the stomach, and when it reaches to a certain point, the irritation is sufficient to give rise to acute pains in all the ramifications of the supraorbital nerves. He also reported dysphagia associated with migraine. Forsgill in 1770 described the visual disturbance of classic migraine and introduced the term fortification spectra. To describe that after breakfast, if much toast and butter has been used, it begins with a singular kind of glimmering in the sight, objects swiftly changing their apparent position, surrounded with luminous angles like those of a fortification. And he described the headache also starts from the stomach and rise up to the head, not the reverse one. And later in 8th century, Rasmus Darwin, the grandfather of Charles Darwin, he believed that headache of migraine is due to a vasodilation and too much blood in the head, and the ideal treatment could be centrifuging these patients. So what might be the consequence of whirling a person with his ear next to a center of motion so as to force the blood from the brain into the other part of the body? So this challenge was taken by Harold Dolph, and he tried the procedure later on. Sir Samuel Wilkes also entertained migraine as a familial disease, and it runs in the family, and whatever produces a strong impression on the nervous system will cause an attack. So these different ways alter the current, the blood flow through the head, which the face is changed to pale, the vessels are throbbing, and the head is hot. Edward Leving, who wrote the first comprehensive work on migraine on his book on migraine, sick head, and some allied disorders, where he originated the neural theory of migraine and ascribed it as a disorder of autonomic nervous system, and he called it a nerve storm or epileptic manifestation. This idea was supported by Hughlin Jackson, who believed it's a form of sensory epilepsy and associated the vomiting and the headache as an epiphenomenon. So later on, different authors believe migraine is more of a vascular disease, so the concept of migraine pathophysiology was shifted from that of a neural theory by Leving to a vascular theory of the current years. This is illustration by John Tinners about the work of Lewis Carroll on his famous book Alice in the Wonderland, and the sequel Through the Looking Glass, where he has depicted his migrainous aura with these distortions of body with metamorphopsia and distortions of surrounding image. And regarding the treatment, ancient Greeks and Romans included reference to ablated grains and darkened brains for using these barley powders to induce or hasten childbirths, and later on there were documenting shows there was ergot poisoning, which are called ignis saccharine on holy fire, where the patient have a gangrene and a sensation in the abnormal sensation on the limbs, where later on they identified ergot from the extract as a pure ergot alkaloid, which was used as a treatment for migraine, and ergot was used later on for acute attacks of migraine, and Gors introduced the Gors mixture using hempes or marijuanas combined with nitroglycerin as a prophylaxis. And the last one is work of Harold and John Graham, where they use IV ergotamine tartarate to reduce the headache versatility and the severe headache associated with migraine. So these are famous migraine sufferers. Thank you.
Doctor, for this nice historical presentation. Just we have one question only. One question only. So we shift back to Dr. Michael Ndoga from Kenya. Welcome from Kenya. We'll talk about neurotransmitter in migraine, the endocannabinoid system in migraine. Welcome.
Good afternoon, everyone. My name is Dr. Michael Ndungu from the Institute of Primate Research, National Museums of Kenya. We are a biomedical facility that specializes on modeling human diseases using non-human primates in order to do pathophysiology and basic science researches pertaining to neurological conditions and infectious diseases, as well as conservation issues. It is well known that many migrainians have a neurotransmitter deficiency, and some of the neurotransmitter deficiencies associated with migraine include serotonin, dopamine, GABA, and acetylcholine. And dietary deficiencies may be a primary precipitant of these anomalies. And frequently, especially in the past when there wasn't much research being done on this, neurologists have employed a priori diets to manage migraine attacks. There are other factors that trigger migraine, including toxins, chronic stress, and recreational drugs, including nicotine, caffeine, and alcohol. If we could start with serotonin, 5-HT, the clinical signs associated with the deficiency include carbohydrate cravings, low libido, digestive disorders, negative attitudes, binge eating, and low self-esteem. And the parent compound for serotonin production is tryptophan. So foods that are rich in this amino acid mitigate the progression of serotonin-associated migraine. The next neurotransmitter we're going to mention is dopamine, whose deficiency is characterized by low energy and motivation, low libido, loss of zest for life, destructive behavior, apathy, lethargy, and anhedonia, and generally loss of the urge to live. And tyrosine is a parent compound from which of the catecholamines, and so foods that are rich in this will definitely assist. For example, fruits, animal products such as apples and avocados. Then we have GABA, which is the principal inhibitory neurotransmitter and contributes to regulating brain function, especially in the face of excitatory amino acid events. And GABA derailment has been associated with recurrence and attacks of migraine. And foods that enhance GABA levels include grains, bananas, spinach, and organ meats. That is, end organ meats like liver, kidney, etc. Acetylcholine was the first neurotransmitter to be characterized, and it is involved in the process of memory and learning. Deficiencies reflect with derangements in these faculties, in terms of memory, retention, focus, concentration, and sequential thinking, as in planning and joining thoughts to make sense. And there are other precipitants of migraine that do not have a dietary substrate, like we mentioned, toxins and stress, that really have nothing to do with the neurotransmitters as such. Now, evidence over time indicates that anecdotal evidence and also empirical evidence indicates that natural cannabinoids from the plant Cannabis sativa can abolish certain forms of migraine. But I would like to clarify here that unless anyone in the audience knows, it is not known in particular which particular compound in this plant mitigates this migraine, pain associated with migraine. And we are planning an experiment which we hope will open a research avenue to find out whether the endocannabinoid system is also one of the neurotransmitter systems that could be involved intrinsically in the pathophysiology of migraine. So our hypothesis is that it is involved, and the null hypothesis is that it is not. And we intend to use, we intend to localize the endocannabinoid receptors. There are 3 endocannabinoid receptors. We have the CB1 and the CB2 and a putative CB3, which I don't know whether it has been characterized yet. But our method is going to use immunocytochemistry to localize these receptors and also establish their neuroanatomical substrate or base. We will perform a neuropathological assessment and as well as the endocannabinoid receptor distribution in autopsy series of migrainias. We'll also perform a neuropathological assessment of non-migrainias of the same age band, and then we'll perform an anatomic comparison of ECS distribution in the brains of olive baboons, which is one of the non-human primates that we use to model central nervous system diseases because of the genetic similarity or proximity with humans, and determine if there is a difference in terms of ECS distribution in migrainias and non-migrainias. We are going to use the baboon work to establish the neuropathological, the neuroanatomical substrates of migraine and use that information to reflect on the human studies. What we are expecting is we'll determine if there's a difference, and we think there might be a difference between the distribution of the endocannabinoid receptors in migrainias and non-migrainias. And from there, we hope to determine whether the olive baboon may be used and developed as an appropriate non-human primate model for the study of the pathology of migraine. And if that is established, then we will engage in the work of developing the baboon as a model for migraine, considering the endocannabinoid system. Those are the references, a few of the references that I had. And I'd like to acknowledge the International Headache Society, our director from National Museums of Kenya, and the director of my institute, and the organizers of this conference. And thank you for listening.
Thank you, Dr. Michael, for this nice presentation. One question.
Thank you for this very lovely presentation. This is the first time we are talking about inducing migraine in baboons. How will you introduce migraine in baboons, and how you know the monkey has migraine?
First of all, we have indicators of pain in animals. It presents with certain signs. For example, there are facial features that can tell you that the monkey is having pain in the head, or their postures that can give you a rough idea of the anatomical origin of the pain. Then from there, we'll mostly rely on the distribution, the difference between the distribution of the receptors in normal and abnormal baboons. Then, as I mentioned, there are neurotransmitter deficiencies, which are associated with the precipitation of migraine. So, what we'll intend in the long run in the development experiment is to to induce those neurotransmitter deficiencies by denying the baboon some of the, by compromising the diet, let's say.
You will do it on alive baboons or on cadavers?
Yes, you will do it on a live baboon. You compromise the diet. Say, for example, if it's a tryptophan deficient diet or tyrosine deficient diet, and then from there, one will be able to establish whether it has developed those features of migraine.
Thank you.
Thank you. We now shift to Dr. Yard Ifura from Ethiopia. He talked about migraine-related disabilities, comorbid depression among migrainiers in Ethiopia, a cross-sectional study. Welcome.
Okay, good afternoon. I came from Ethiopia. This is a study that we did in our university. The title is Migraine-Related Disability and Comorbid Depression among migraineurs in Ethiopia. It was a cross-sectional study. It was published 2 months back in BMC Neurology. I came from a country with 81 tribes of various kinds. We have the highest altitude here, it's more than 3,000 above sea level, and the lowest place on Earth, actually that's called Dalul, that's the lowest place on Earth, is 120 meters below sea level. So when we did this study, the main aim of this study was to examine migraine-related as you know, depression is common in migraine, and migraine is associated with a lot of disability. So we want to study the correlation between migraine-related disability and associated comorbid depression. That was the purpose of the study. We did a diagnosis of migraines that we did was based on the ICHD-3 diagnostic criteria, and all our patients were above the age of 30. 30 is the limit that we classify pediatric and adult patients in our country. One of the main exclusion criteria was that all other types of headaches were excluded. If they do have additional kind of headache, like tension type headache and the like, we exclude patients. When we see the association signs, it's known that migraine is associated with a number of psychiatric illnesses, depression, bipolar illnesses, and other lot of psychiatric illnesses, but depression is commonly associated with migraine, and it's one of the most disabling situations. And it's said that patients with migraine are 2 to 4 times likely to develop lifetime major depression, and studies vary in different countries, and in some studies up to 80% of migraineurs do have depression. Issues that in the presence of depression, in migraine increases disability, and when they do have depression also, it will be associated with greater severity. These things are highly related. It's known that patients with severe disability are 6 times likely to develop depression than those with lower disability or no disability. This is a patient in my hospital. He was a guard, always having headache, and we ask him to come to our clinics. He doesn't usually come. He just takes his anti-pain and always with his mobile. So the study was done in 2 referral teaching hospitals in Addis Ababa. It was conducted over a period of 7 months, and to assess this association, we used two scores, assessment scores. One is MIDAS, and the other was PHQ-9. We used MIDAS to assess disability, and we used PHQ-9 to assess severity of type of depression and severity of depression. PHQ-9 is a 9-question depression assessment scale, very simple to do, and this PHQ-9 was validated in my country as a depression scale. And MIDAS again is also a migraine disability assessment score, and again it's very simple to apply. Anyone can use it in any clinic. So we use these two scales. Based on this study, we use analytical statistics, including bivariate analysis with Spearman's correlation were performed to determine the correlation between disability and depression. When we come to the results, we did a study on 70 patients in these two clinics, and 3/4 of our patients were females, and the rest were men. And the majority were in the age group 20 to 40 years, non-productive age group, and only few were greater than 14 years of age. And it's a known fact that migraineurs do have their headaches get exacerbated during menses, and in 31.5% of our patients there was worsening, and also we found out that there was association between migraineurs during menses and the severity of disability was very high. Actually, there are studies done also in other countries, particularly associating migraine during menses and disability level. As in any other country also, in our studies, the majority of our participants were having migraine without aura. As you see, educational status was also higher. Actually, this is a referral hospital, and people who come to this center are people who know what kind of center is it, and there are also physicians who can treat headache and the like. That's why that you see a majority, a lot of them do have a good educational level. The duration of migraine determines the level of disability and also the presence or absence of depression. So we did that, and the majority of our patients were diagnosed to have migraine in less than 5 years. That means their migraine diagnosis was known in less than 5 years. And we also did a study on how many of our patients were on migraine prophylaxis treatment, and we did that just to see, because a lot of our patients are on amitriptyline as a migraine prophylaxis. So there is amitriptyline, as you know, is an antidepressant, so it might have some effect on their level of depression and then by relation to their disability. So the majority were on amitriptyline, and the rest on propranolol and imipramine. The other result, after doing these tests, the mean PHQ-9 score was 9.2, plus 4. Severe depression was seen in 14.3% of our patients, and minimal or no depression was seen in 12.9% of our patients. When we see the MIDAS score, severity of disability, as you see, 74.3%. The majority of our patients were having severe disability, having a score greater than 21, and only 1.4% with little or no disability. When we did the Spearman's correlation to examine the associations, we found out that there was a significant correlation between severe disability and depression for both minor and major depressive disorders in comparison to those with no depression. Yeah, this is a relation. So depression was associated with the occurrence of severe disability, and severe disability was found to be 8 times more common in patients with depression in comparison to those having no depression on this study. When we finalized the study, most of our patients were female, 2/3 of them, and a significant proportion of study participants fulfilled the criteria for major depressive disorders, and many of them have severe disability. And also, we found a strong correlation between disability and comorbid depression among migraineurs. And also, there were also a lot of government employees. When we assess why there were a high prevalence of migraine-related disability in our study, I think we found that it's a hospital-based study, and the majority of patients coming to this hospital do have a referral from general practitioners, so they must have severe kind of headache, and also they have passed a lot of steps to arrive there, so that might be a factor for having a lot of patients with severe disability. Secondly, in general, headache management in our country is not good, so a lot of them were having managements which do lack the level of standard, so they were mismanaged, we were having a lot of medication overuse headaches and the like, so by the time they arrive, they do have severe form of disability. So in conclusion, there was a positive correlation observed between migraine-related disability and comorbid depression, and we recommend that every patient coming with migraine should be screened both for depression and for disability, because having these two comorbid situations affects the way we manage them and their outcomes. So if a person has severe disability, we'll guide our management based on the level of severe disability, and the follow-up also depends on that. Thank you.
Thank you, Dr. Riyad, for this presentation. I think we have no time for question. We shift to Dr. Wafiq Banasi from Egypt, Tanta. He will talk about spontaneous intracranial hypotension, swings between over and underestimation.
Good afternoon, everyone. Thanks for your attendance and greeting for chairpersons. My talk is about spontaneous intracranial hypotension, which is one of the commonly missed diagnoses. As we know, the normal CSF pressure is about from 80 to 180 millimeter water, and the normal CSF volume is 160 milli distributed in the subarachnoid space, in the interventricular system, and in the central canal of the spinal cord. Intracranial hypotension is a neurological condition occurred due to low CSF volume, which is called volumetric intracranial hypotension, or low CSF pressure, which is called barometric intracranial hypotension, or both, attributable to CSF leak through a dural defect. One of the first who described intracranial hypotension is the German neurologist George Scatlenbrand, who named it alikoria, or absent CSF, then updated this term to hypolikoria. The international classification of headache put the headache attributable to low CSF pressure, divided it to post-dural puncture headache, CSF fistula headache, which occur either due to surgical procedures like shunt procedures or over drainage shunt, or CSF trauma. And one of the focus of this presentation is the headache attributable to spontaneous intracranial hypotension. CSF leak will result in vertical downward sagging of the brain, which will result in traction of the intracranial structures, resulting in orthostatic headache, which is the basic and sine qua non of spontaneous intracranial hypotension. The headache worsen in upright position and disappear in recumbency. The severity of headache is proportional with the dural defect and the degree of CSF leak. The non-headache manifestations include the neck stiffness, cranial nerve pulses, the second, the oculomotor nerves, the trigeminal, the facial, and the eighth nerve can be tracted. Spinal radicular syndromes occur at the site of the CSF defect and the dural defect, galactorrhea, dural sinus thrombosis, coma, or encephalopathy. The ICHD-3 diagnostic criteria of spontaneous intracranial hypotension is headache in temporal relation to low CSF pressure or CSF leakage, either or both of CSF pressure below 60 mm water, evidences of CSF leakage, and absence of a procedural or trauma known to cause CSF leakage. Spontaneous intracranial hypotension usually occur due to rupture of a meningeal diverticula, which usually occur in heritable connective tissue disorders like Marfan syndrome, Ehlers-Danlos, autosomal dominant polycystic kidney. The dual diverticula are usually located at the site of the exit of the spinal nerves, which is the weakest points of the dura. The defect occur either during vigorous exercises, straining, coughing, sneezing, etc. Intracranial hypotension constitute about from 0.5 to 1% of all headache presentation in the emergency room, with yearly incidence of 2 to 5 per 100,000. Initial misdiagnosis is common, which subjects the patient to unnecessary procedures, workup, and treatment, and some of the patients, the mean time of correct diagnosis may reach up to 13 months. How I diagnose spontaneous intracranial hypotension? The suspicious CT can be put here. There is bilateral subdural hematoma or subdural hygroma, especially in young individual which has no bleeding tendency. Also, we can notice the backmeningeal engorgement in such patient. The MRI is important in the diagnosis. The non-contrast MRI will show widening of the superior sagittal sinuses and the transverse sinus. As we know, the superior sagittal sinus is triangular in cross section, and here we can notice the dilatation by become rounded superior sagittal sinus. When I put enhancement, there will be non-nodular backmeningeal enhancement of the dura and underlying subarachnoid membrane. We can notice also flattening of the normally convex corpus callosum, decreased mammillary pontine distances, decreased pontum encephalic angle due to downward brain descent, also downward descent of the cerebellar tonsils, which will result in Chiari-like displacement. One of the important also is increased anteroposterior length of the midbrain and hyperemia of the pituitary gland. Some techniques like magnetization prepared rapid acquisition gradient echo MRI may show shortening of the supracellular cistern height, pituitary height, and prepontine cistern due to forward pushing of the bones and midbrain. The optic nerve will be tracted by the downward brain sagging, so we can find the reverse of the idiopathic intracranial hypotension. There is decrease in the optic nerve sheath diameter and straightening of the optic nerve. Myelogram can find the site of the dual defect and can diagnose the presence of diverticula. Myelogram may be done by MRI or radioisotope cysteinography. The prognosis of spontaneous intracranial hypotension is variable. Patients with a small defect may be present by mild symptoms, but patients with severe CSF leak may be presented by severe orthostatic headache, which may make the patient crippled and can't raise his head. Patients may deteriorate with the development of cranial nerve pulses, sinus thrombosis, large vessel strokes, encephalopathies, or even coma. The usual rule of management in small defects is the conservative measurements with strict bedridden, keeping the patient bedridden in supine position or mild Trendelenburg position, ample hydration and analgesia. Non-targeted epidural injection by 10 to 20 millivenous blood give success rate up to 80% and may need to be repeated. CT-guided targeted blood patches or fibrin glue at the leak site is also effective. With large dual defect surgical repair and the clipping of the aneurysm of the diverticulum by aneurysmic clip may be needed, or muscle patch. Now we can conclude the presentation. When do you suspect spontaneous intracranial hypotension? Suspect it when a patient is presented by recent onset orthostatic headache. The orthostatic headache may take a lag time to be presented, may take 5 to 10 minutes to appear after upright position of the head. Bilateral subdural hematoma or hygroma, subdural hematoma in a young individual with no bleeding tendency, subdural recollection after evacuation, imaging character of vertical brain descent, unexplained persistent cranial nerve pulses. Headache due to spontaneous intracranial hypotension may lose its orthostatic characters with time, especially when subdural collection takes place. Epidural blood patch alone is followed by resolution of the subdural hematoma in about 80% of cases. So subdural hematoma must not be evacuated before closure of the CSF defect because it will result in recollection and increased brain sagging due to the presence of a skull defect. This is my used references, and thank you for your attention.
Thank you, Dr. Wafi, for this nice presentation. And I will ask a small question. What about sport, which will lead to diverticulum to be ruptured? What type of sport? ايه الرياضة اللي تخلين الديفرتيكولم ده تتقطع ويحصل هايبوتنشن؟
What?
سبورت. ايه انواع الرياضة؟
The dura is in spontaneous intracranial hypotension is originally weak. So there is a dural diverticulum at the exit of the spinal nerves. The weak, like aneurysm rupture, the dura may rupture and result in CSF leakage. This is the spontaneous intracranial hypotension. But some types of intracranial hypotension may be traumatic, may due to surgical procedures, may occur after post-lumbar puncture needles. So we must, during spinal, not to introduce the needle multiple times to avoid the CSF leakage and the presence of and the development of spontaneous intracranial hypotension.
Can diffusion tensor imaging for optic help to diagnose us with intracerebral hypertension؟ لو احنا عملنا diffusion tensor imaging للاوبتيك نيرف ده ممكن يساعدنا في الدياجنوزس في hypotension؟
Optic nerve in idiopathic intracranial hypertension like Dr. Nermin will the optic nerve sheath diameter will be increased due to increased intracranial pressure. But in idiopathic intracranial hypotension, the two things will result in decrease in the optic nerve diameter. The first thing is the traction of the optic nerve by the downward plane sagging, and also due to decrease in the intracranial pressure, which will result in decrease in the CSF around the optic nerve.
Can help us. Okay, thank you, Dr. Wafi. We shift to Dr. Muhammad Abdul Hamid from Egypt, the last speaker. He speak about prevalence of migraine in Upper Egypt.
First of all, I would like to thank my Professor Osama and the organizing committee for this great effort. My presentation about prevalence of migraine in Upper Egypt. The importance of migraine comes from that disease that has a tendency to chronify if not appropriately managed, and it affects the workforce segment of the population. Epidemiological data are important not only to improve our understanding of the condition, but also to allow a rational approach in planning a health service. door-to-door study, population-based study, which mainly depends on structured personal interview, is much more accurate than other related study. For example, hospital-based study, self-reported questionnaire, and data collected from medical records. So the aim of the present study is to evaluate the prevalence of migraine headache among the population of Al Qusayr city and its impact on the patient's life. The Red Sea Governorate is the longest governorate in Egypt. All its cities lies directly on the Red Sea with a distance of around 1,080 kilometers. There are 6 cities in the Red Sea Governorate: Ras Gharib, Hurghada, Safaga, Al Qusayr, Marsa Alam, and Shalatin. Al Qusayr city is the second largest city in the term of population size. Method. This study is a part of door-to-door survey of major neurological disorders that was conducted in Al Qusayr city, Red Sea Governorate, over a period of about 2.5 years. The project was carried out on eligible inhabitants who have been living in Al Qusayr city for at least 6 months at the time of the study. 33,285 persons were screened through door-to-door, including every door, by 3 specialists of neurology using a standardized validated Arabic questionnaire. 15 social workers accompanied the specialists during the house visits to collect demographic data. The positive cases were subjected to meticulous clinical and neurological examination for case ascertainment. Cases were classified according to the diagnostic criteria of the International Headache Society. Functional disability was assessed through evaluation of the impact of the disease on the patient's daily life using the Migraine Disability Assessment Scale. Lastly, patients were asked about medical consultations and the medicines used during and in between the attacks. And we calculate the treatment gap. The definition of the treatment gap is the number of patients who have active migraine not on treatment or inadequately treated, expressed as a percentage of the total number with active migraine. The importance of the treatment gap comes from it reflects the health care and the public awareness of the population. As we mentioned, 33,285 persons were screened. More than half of them were females. Around 41 persons were married, and only about 18 persons have higher education. The prevalence of migraine in the present study is 3.38%. The highest age group that has the highest prevalence is the age group between 18 and below 40. As regards the sex prevalence of migraine among the study population, except for the age group below 12, the prevalence of migraine is more common among females than males. This reflects the inverted U-shaped pattern of the prevalence of migraine among different age groups. The migraine prevalence peak at the age of 40 and then decline after that. As regards the frequency of migraine, migraine without aura is the most frequent type, followed by migraine with aura, and lastly, probable migraine. Migraine Disability Assessment Scale revealed that about 68% of the studied patients have moderate to severe disability, and this reflects the impact of migraine on the patient. One of the important results from our study is the treatment gap. As we mentioned, treatment gap, we divide the number of patients not on treatment or inadequate treatment by the total number of active migrainous patients. Here, the figure is 91.5%. And these higher figures reflect that most of the patients, as we found, received only analgesic anti-inflammatory. In conclusion, lifetime prevalence of migraine is 3.3%. Migraine headache has deleterious impact on the patient's function and well-being. Thank you.
Thank you, Dr. Muhammad, for this nice presentation. Just to have one question, if you have any, Dr. Atzel.
Thank you very much for your nice lecture. Regarding you said that the most of your patients inadequate treatment, as you said, taking non-steroidal anti-inflammatory and so on. This is because they were not diagnosed as migraine, or they diagnosed migraine but not taking
one of the explanation for this result, this area has no neurologist.
No diagnosis. Wrong
No
diagnosis. Headache, just
this
headache.
patient to seek medical advice, he has to go to a suit. So far.
No diagnosed.
Yeah.
Regarding questionnaire.
So management is depend on primary care.
Regarding questionnaire, you study the age from 6 years. Questionnaire, can you perform this questionnaire for patient with 6 years or 7?
Already in our university, we have a well-established questionnaire for screening for all neurological disorders. And this was validated before. And we have published many studies before in this questionnaire.
No, I want your experience. Because I want your experience because the disability scales of migraine, we perform it for patients not less than 18 years because it's very difficult to explain the questions. I want to ask you, when you deal with a patient with 6 years, 7 years, how you explain this questionnaire to him to answer you? That's my question. It was easy, it was difficult. No. How you can perform this?
The value of the questionnaire is used during the door-to-door survey.
Yes.
But with accused cases or positive cases that may have a headache or migrainous headache were assessed later on the hospital of Al-Qusayr City in details. Not on door.
Thank you.
Thank you for this attendance. We have shifted to another session. دكتور عبد الله مأمون سرحان، دكتور محمود حميدة، ودكتور شريف حمدي. اتفضلوا.
Bismillah ar-Rahman ar-Rahim. We'll start session of pathophysiology and diagnosis of migraine by Dr. Peter Goodspree from UK, Professor of Neurology, King's College London, Chair of British Association for the Study of Headaches.
Thank you. I was asked to give an update on migraine pathology in a constrained time frame. So what I decided to do is just pick on a couple of things where there's change, because a lot of things are changing, as you might have guessed already. So if I start from a clinical perspective, thinking about migraine as a disorder of attacks of migraine, and thinking about what's been classically described as the phases of migraine, the premonitory phase, the pain phase, and the postdrome. I think one of the insights from what's happening in the functional imaging world is that, and I think also from clinical phenotyping, that the concept that there is distinct phases that run linearly is almost certainly correct. So
bearing that in mind, all of these phases, if you like, at some point have some overlap. Broadly speaking, I refer to the premonitory and premonitory-like symptomatology as things that start before pain, and then I would refer to postdromal symptoms as things that are dominant after pain. But I think it's important to recognise that there's an overlap. I'm going to concentrate on the prodromal or premonitory phase. The latest incarnation of the ICHD equates premonitory and prodromal as being equal terms. We've agonised over this for a while. It seems like a reasonable thing. Getting caught in the weeds of that is not very helpful. The ICHD describes the premonitory phase as occurring in the hours, many hours very often, before the onset of head pain. At some level that's immediately wrong because that symptomatology extends into the headache phase, but it's a useful conceptual place to start. I wouldn't get hung up about where some of these symptoms appear. They're very common: tiredness, concentration problems, neck stiffness, mood disturbance, yawning, thirst, food cravings. They're things you can easily talk to patients about. I've listed on the right side some symptoms that clearly occur in the premonitory phase, but are not canonical, if you want. They're not typically associated with it. So it's not unusual to hear of patients have photophobia or phonophobia before pain starts. Nausea, cranial autonomic symptoms. We documented all of those in the premonitory phase. I'll return to this because if you start to think about, if you step back and think about it all together, you can start to think about many of the things patients say in a very, very different way. The basis for thinking about this are clinical studies. This is one that Nicola Giffen, Steve Silberstein, Richard Lipton and I did some years ago, which asked patients to track their symptoms and to give an indication as to whether they thought they'd get a headache. And you see that many, many hours, just to illustrate, is this coming up? Good. Illustrated here, many, many hours before the pain starts, the patients are getting their symptoms. And this is the range of symptoms that they have. Tiredness and neck discomfort are very, very common symptoms in this phase, and indeed they run into the headache phase. Yawning is particularly attractive because yawning 96% of the time went on to have headache, and the biology of yawning itself is very. Let me say in parentheses, thinking about those of you early in your career, think about research, you can pick on these symptoms and you can dig into them in considerable detail. So there's quite a lot to offer here in terms of the biology of understanding the earliest part of what's happening in the attack. This is imaging work that Farouk Maniar led on when we were in San Francisco, and it illustrates two things. It illustrates activation in the hypothalamic region, the midbrain, and the pons during the premonitory phase. No pain. So without doubt, this activation process doesn't require pain. It predates. It's also true that you can see that patients will tell you about these symptoms running across into the headache phase. Most recently, Nazia Kazan presented this work at the Migraine Trust meeting in London a month and a half ago, where what we've done is look in some greater detail at the functional imaging manifestations of the premonitory phase using arterial spin labelling techniques. We previously used water-labelled PET, but you can't keep doing that because of the radiation dose. So what we're showing here is triggered migraine attacks with nitroglycerin and activation in the premonitory phase. And we see activation in the orbitofrontal cortex, in hypothalamus, in thalamus, amygdala and basal ganglia. So a range of interesting areas that you could begin to use to explain some of the very complex phenomenology that occurs in the migraine attack. And in the pain phase, dorsomedial and central medial thalamus is quite interesting. I won't go into it in detail, but when you can correlate that actually some work that Till Springer and others did in collaboration to look at volumetric changes. We heard some discussion a little bit earlier in one of the free presentations about volumetric change in the brain. And indeed, this area of the brain is one that has volumetric change in migraineurs compared to controls, and indeed has some interesting animal correlates in terms of FOS activation that I won't go into. Now, if I just concentrate on yawning for a moment, I want to illustrate something about the utility of taking these clinical symptoms and then trying to understand them. It turns out that if you give dopamine to migraineurs, they're more likely to yawn than age and sex-matched controls. Indeed, you can make rats yawn with dopamine. We don't understand yawning terribly well. It's a social, we think it's got a social function. So when, if anyone yawns at me during the presentation, I don't take that as you being bored. I take that as you wanting to have a sort of social interaction with me, a kind of bonding thing. So whenever you see your audiences yawning, just be happy that they're socially bonding with you. Better if they stay awake, it has to be said. You can use that with your spouse when you try to explain why you're not being interested in what they're saying. Tell them it's a social bonding experience. If you want to study this, well, what we've done is start to look at the dopamine questions, and these are some data, the first of the data that we looked at. We start to ask the question, well, if yawning is an early part of the attack, and if dopamine is involved, how would that work? So what you could do is you can show that there are dopamine receptors in the trigeminocervical complex of rat, D1, 2, 4 and 5 receptors. You can record from these neurons, as Astrid Bergeron did here, and you can show that intravenous dopamine does nothing. But if you record from these neurons with an ionophoretic device, you can show with increasing current that you can turn the neurons off with dopamine, and you can show the quantitation here. So there's a dopaminergic gating mechanism in the trigeminocervical complex. Okay, you can show that it probably comes from A11. The A11 nucleus is sitting here, is just medial to the mammillothalamic tract. This is a coronal section, it's a ventricle, third ventricle, and this is staining for tyrosine hydroxylase and dopamine beta hydroxylase. So you see the A11 neurons can't go on past the dopamine stage, and if you stimulate that area, you can show that a middle meningeal dural activated neuron in a rat can be inhibited, and you can reverse it with a D2 family antagonist. So, it supports that concept. And perhaps more interestingly, if you lesion the A11, as Annabelle did, then you get a facilitation of transmission. And you can link that into an interaction with triptans. You can show this is the facilitation with lesioning, and this is the facilitation being reversed with narrowtriptan. And you can indeed show that there are both 1B and 1D receptors along with dopamine receptors in trigeminocervical complex. So there's a dopaminergic interaction with triptan receptors. It's occurring in the trigeminocervical complex. It's being driven from a hypothalamic region, and when it doesn't function properly, there's a facilitation. Okay, what do I learn from that? The archetypical thing that happens, the core of migraine pathophysiology is a misinterpretation of normality. Photophobia is the best example of this, the simplest example. People with photophobia do not get extra stimulation, they don't get extra photons. What they get is a misinterpretation of the same number of photons. Facilitation, just as you get if you lesion A11. Now, I don't think that migraine is an A11 dopamine problem, but I think it's a system neuroscience problem of dysfunction of our normal regulatory mechanisms. It's complex, but make no apology for that, the symptoms are complex. What have we been doing with aura? This is the classical picture of Oleson's that he observed the spreading oligemia in patients with aura, and this is work from Hajikani in Moscow. It's the captured patient in functional imaging experiment, again with the spreading oligemia and of course the fortification spectra that come of that. We've been interested in trying to understand links between the areas involved in migraine, such as the PONS, here shown with triggered nitroglycerin, Anish Bara, and Shazia Rafidi showing spontaneous, with Nicola Giffen showing spontaneous pontine activation. Back then we wondered whether this was due to pain. Clearly isn't, because you can see it in the premonitory phase. We were interested in the question in the lab whether you could link this in some way to understanding this process of migraine aura. So in this study, Madhavia with Phil Holland looked at the question of whether one of the structures in this area that would do nicely is the locus coeruleus. It's got 96% of brain noradrenaline. So what they did was to disrupt the locus coeruleus. Here it's intact, and here it's been disrupted with a neurotoxic, noradrenergic neurotoxic poison, DSP-4. And what you see is a change in the threshold for cortical spreading depression. So here, in electrical induction, the level of stimulation is reduced, and here with KCL, the number of CSDs you get with the potassium chloride induction is increased. If you disturb locus coeruleus noradrenergic function, the brain of an experimental animal is more susceptible to cortical spreading depression. Thinking about the subcortical areas to the cortical phenomenon of spreading depression. And it goes to the general thesis that I want to develop with you, that migraine is fundamentally a subcortical, if you want, a diencephalic brainstem control problem, and the cortex in many ways is a bystander of that. Now, one of the other consequences of starting to think about the premonitory phase, and it frees you up from, why I'm interested in is it frees me up from having to be concerned that pain is driving the phenomenon I'm looking at, because they don't have pain in the premonitory phase, is to start to rethink about triggers. People come to see us all the time, a list of triggers that if they'd avoid them, everything will be fine. And the lists are long, and most of them are just nonsense, I think, and particularly many of these dietary trigger things. So I want to explore some ideas around triggers. In this analysis, what Farouk did was to look at patients who we triggered into the premonitory phase and had photophobia, and compared them with those we triggered in the premonitory phase and didn't have photophobia. And unsurprisingly for the neurologist, the difference is in the visual cortex, unsurprisingly. You pause on that, think about that for a moment. Patients in the premonitory phase can have light sensitivity. Very commonly, patients will tell you that lights trigger their migraine. Now, it's possible that's true. It's also possible that lights don't trigger the migraine at all. It's that they notice light in the premonitory phase, day or two beforehand, and they associate that noticing, this light sensitivity, with their migraine coming. So they make the correct association for the wrong causal reason. I think it's a way of standing back and thinking about, say, understanding some of these dietary things. Brain cravings driven by the hypothalamus. Patient takes something like chocolate, for example, the classic silly idea, I think, takes it and then makes the association. Right association, wrong causal reason. As we understand the biology, this sort of explanation is, I have to say, is very attractive to me. This has been tested to some extent. The Danes tested this in a cohort of patients who claimed very clearly that they could trigger their aura if they, with light, and they tried their best, torturing them with visual evoke potentials and stroboscopes and so forth. Not a single one could be triggered. Now, you could say that's because they've come to the lab, they've got our Danish colleagues are grilling them, and that was enough stress to stop them having a migraine. Or you could accept that some part of what's going on in this so-called trigger world is really the realisation of the premonitory symptomatology. I can spend 20 minutes just picking on yawning or light sensitivity. There's such a rich biology in migraine because it's a complex brain problem, and unexpectedly there are many opportunities to study it. The brain, it's key to understanding these networks. And as we understand, of course, the neuropharmacology of these networks, we both develop an understanding of the symptoms, the phenotype that we can explain to patients, and we develop new ways to treat migraine. There just is nothing more exciting at the moment in clinical neurology than migraine, because we can understand the biology and we can do things. It's exactly treat patients, exactly what we got into medicine for. Thanks very much.
Any questions? Thank you very much.
Thank you.
Thank you very much.
Now I will introduce Professor Hayronessa Boulay. Is it correct? From Turkey, Professor of Neurology, Doctorate, Hacettepe University Institute of Neurological Science. Speak about sensorial processing disruption.
I will talk about some sensorial, symptoms associated with migraine headache, and just think about the possible locations of those disruptions. As we all know, I will skip several of them because that was prepared for more than 20 minutes of talk. But let's start with how we diagnose the migraine. So we have the pain in the trigeminal first branch. It's unilateral pulsating. The duration is very important, but also we have those sensorial problems associated with pain, which is very important for us to diagnose it. And let's think about what makes the photophobia, phonophobia, and or osmophobia thing. During the headache, the nociception from the head, there is the perception goes to the trigeminal cervical junction up to the cortex, but on the way there is medial pain pathway, and also this is the lateral pain pathway. We always talk about this, which ends in the somatosensorial cortex, and it's important to discriminate the sensorial stimulation. But it's also important to know that with the C-fiber activation of affective motivation, which includes the anterior cingulate cortex and insula, and also the cognitive evaluation, which occurs in the prefrontal cortex. I'm not talking about those important nuclei in the thalamus. They're really important for the sensorial disruption. So we know that this cortical spreading depression is associated with pain as an initiating factor, and that data shows us that in humans with the traumatic brain injury and also in mouse, all the cerebral cortex are not evenly, akin to the spreading depression. As you see, in the parietal lobe, in the sensorial cortex, is the most sensitive one compared to the others in the frontal lobe and also, all the middle temporal lobe. So that tells us that something is more important for the sensorial cortex. Also, probably the clearance of potassium could be implicated, or more than one factor is important in that case. But we are always thinking cortex as a single entity. We have to know that the cells in the layer 4, 3, and they all connected to each other. They are also connected to the thalamus. You can see to the thalamus to the subcortical areas or associative thalamus. So there is a huge connection between cortex and thalamus. When the sensory stimulus comes, it usually comes to the first order thalamic relay nuclei, then goes to the first order cortical area. Then it bounces, like those oscillations that bounces to the higher order thalamic relay, then the perceptual cortical area, then back again the thalamus, then the association area of cortex as a third one. So while those things, oscillations are occurring, we know that that has to be controlled. That control is usually goes through the thalamus, the cortex, and there is a reticular nuclei of thalamus, which lies in between and sends inhibitory GABAergic neurons to the thalamic relay nuclei, and it's a gatekeeper of sensory outflow to the cerebral cortex. It is involved in selective attention, lateral inhibition, and discrimination of sensory stimulus. So it's very important structure, and we were able to show that, we were able to study that structure in experimental studies. So when we look at the migraine again, we have, visual, auditory, and somatosensorial senses plus trigeminal one, and they can all be controlled by trigeminal nucleus caudalis. So one structure could explain us the problems occurring in the cerebral cortex. What we did, we did the cortical splitting depression in the animals, and we were able to show for the first time that yes, thalamic reticular nucleus was activated by cortical splitting depression. That activation was occurred only in awake animals, and that was the trigeminal thalamic reticular nuclei. This is the ophthalmic visual branch. It has 7 sectors, but the visual sector was much more important, and that activation was blocked by Waprod and also CGRP receptor antagonists. And we thought this is the direct propagation of cortical spreading depression waves, as we showed also with the electrophysiologically in other group of experiments. More importantly, CGRP receptor antagonists were able to block that activation also in the thalamic reticular nuclei, in addition to the trigeminal nucleus caudalis. So they can stop pain, they can also modulate the thalamocortical oscillations. So the dysfunction of GABAergic neurons in thalamic reticular nuclei could be result enhanced transmission to the sensorial cortex and hyperresponsive cortex. That may be one of the explanations for photophobia and also the other sensorial increases. Actually, the thalamus is one of the recent focuses. And early high-frequency oscillations, which occurs during the evoked potentials before N20. This is the early, this is the late one. The early phase is related to the thalamocortical oscillations. There are many studies, but the studies are not conclusive. Some of them, at least many of them, show that there is a increased involvement of thalamic high-frequency oscillations, and also lateral inhibitions are reduced interictally, and they normalize during the migraine attack. And they also show that the late phase is intact, but everything happens also during the early phase. But the other studies are not confirmed. They did not confirm the earlier other studies. Also, we have some, confirming studies from the imaging showing that the resting state fMRI, there is a problem with the cortex and thalamus talk. So we thought, if this is the case, can we show any problem with the sensorial stimulation and discrimination of somesthetic perception. So we hypothesized that somesthetic perception and cerebrocortical processing of somatosensorial information is disrupted during migraine attacks. We use somatosensorial temporal discrimination test, which is well known, and it is very important to allow brain to process information to select the accurate entry of each external stimulus. And it's a cortical census. What we did, the pair electrical stimuli with the interstimulus interval was changed. And in the first part, we used C7 and V3 areas. We selected those areas for stimulation, and we only selected the unilateral headache migraine patients. Patients were migraine without aura patients. They were episodic migraine. They were not on a preventive use. So they were all tested within 6 hours of an attack. And also we tested the same patients within interictal period. So with the healthy volunteers and during the interictal phase, the sensorial discrimination were almost the same, around 35 milliseconds. They were not different. They were not different in the face or hand. But when it comes to the migraine attack period, you can see the stimulation, sensory stimulation coming from the contralateral hand was significantly prolonged. Then we also saw the prolongation of the ipsilateral hand, the ipsilateral phase. So that prolongation was significantly important, and that was transient. After the headache resolved, that prolongation also returned to the normal values. So the transient disruption of central processing of somesthetic stimuli, that was the first time we showed this, and that was very important to understand both cognitive and sensorial perception problems during the migraine, and that might have also a diagnostic value. And that was almost 3 times the normal value. Normal individuals discriminate 2 different stimuli within 20 milliseconds, but during an attack, even exceeding 100 milliseconds, they cannot discriminate whether this is the single or 2 stimuli. Then we looked at this in a tension type headache, because this is one of the diagnostic difficulties occurring in the tension type headache. Its prevalence varies, from 5 to like 80%. Could it be helpful in chronic migraine patients and also medication overuse headache? When we checked with the episodic migraine patients with tension type headache patients, again, this time we only used the C7 from hand stimulation. What you see here, the tension type headache patients, both hands, are not different. They are comparable to the normal individuals, healthy individuals. But on the other end, the migraineurs, the episodic migraine patients, ipsilateral and contralateral, they were almost about, 60, 75 milliseconds. So that could be helpful to differentiate tension type headache and migraine. And also important thing is both patients were having trigger points showing some central sensitization, but the sensorial discrimination was only disrupted in migraine patients. We also checked this in the chronic migraine patients, and during the chronic migraine patients, the STD test showed sustained elevation during the headache-free period and also during the headache attack period. So that could be also used to monitor the chronic migraine patients, actually. You could see all the results were above 100 milliseconds. Now we had 15 chronic migraine patients and 15 healthy volunteers in that study. So it could be also used as a neurophysiological marker during the chronic migraine patients' follow-up. So There is also some, recent imaging studies which shows us that during the interictal period, the green part is when they put the seed to the pons, you see only the green part is connected, but during the migraine attack, you could see all the somatosensorial, primary sensory cortex is involved with this activation. So the other issue is, what if the is it the cortex really hyper or hypoexcitable during the attack? There are also several studies which shows that there is an excitability increase or decrease. So we would like to test the excitability status cerebral cortex in migraine patients. In that time, that test was also not studied in migraine. We used short latency afferent inhibition called SAI. It shows us it is a modulation of motor response by a sensorial stimulus. So there is a sensorial stimulus comes and drives the motor response. With the median nerve activation, stimulation, and with we used, there are several methods, but we used 21 millisecond delay interval after the median nerve stimulation. We use the transcranial magnetic stimulation to the motor cortex. In normal individuals, we show some inhibition. The inhibition is around 60 to 80% of inhibition in the cortex. What we observed when we took the migraine patients during the attack, the inhibition in healthy volunteers and interictal period was totally reversed. The inhibition reduced. Not only reduced, we also show facilitation in the motor cortex. That was really, several hours before. We have 5 patients. We were able to test them during the preictal period. But during the preictal, the motor cortex, cerebral cortex, was unable to inhibit coming sensorial stimulus. Actually, it facilitates that stimulation. That paper is under revision now. But as a conclusion, I would like to tell you that, that there are certain structures in the brain that we ignore them. One of them is thalamus and thalamus-reticular nuclei, and also thalamocortical gating is really important. We have to check, we have to test, we have to find ways to test that structure. And probably cortical excitability change. Okay. The thalamus-reticular nuclei involvement could explain us many features of migraine. That's really important, including the sleep. Sleep and sleep spindles are also originated from thalamus-reticular nuclei. And I would think that central processing of somatosensorial stimulus, probably other senses are also disrupted, and could be, the vertiginous features. Vertiginous migraine could be also the multisensorial association problem in the cerebral cortex. So those tests, those hypotheses has to be tested in migraine patients. And also we need to check the SAI problem, and also the cortical excitability could help us to understand, or offers another explanation for migraine cortical excitability. This is our team, both in the laboratory and also in the patients. They do the electrophysiological studies, and I would like to thank them. Thank you very much.
Any Thanks to Professor Aranessa for this valuable and comprehensive lesson.
Now we are shifting to the next speaker. It is my pleasure to introduce Professor Hassan Husni, Professor and Chairman of Neurology Department, Cairo University, and his talk is about a very problematic issue, migraine and epilepsy.
Good evening. First, I'm really happy that we are hosting this Mena headache meeting, because I think it's really important about the topic of the clinical headache patients we see every day in our clinics. As you can see from the title, that I'm not a headache expert, but I'm an epileptologist. So I'll be discussing with you my perspective, the epileptologist perspective, regarding the management of the epilepsy patients regarding the comorbidities. And I remember very well, this was 20 years ago when I first went to Barcelona for the headache meeting. And I thought I'll be meeting maybe 200 people, and I found thousands there attending the Congress. Maybe Dr. Silverstein remembers this. And a lot of paintings, patients drawing their auras, and it was really interesting. And from that time, I thought headache is part of our, whatever you are specialized, you have to understand headaches, because it's a comorbidity in different neurological problems. From my point of view, of an epileptologist's point of view, we classify patients. It's a very simple classification, whether it's a focal epilepsy or a focal onset seizures versus a generalized epilepsy. Of course, we have a lot of classifications now, a recent classification, but this is a clinical approach to when you see epilepsy patient. Our aim, of course, actually is to control the seizures. This is the success of treatment. The comprehensive approach to the epilepsy patient should include the comorbidities. We frequently encounter patients with depression, with headaches, and sleep disorders. And that comorbidities might contribute to the failure of medical treatment or seizure control. And in a very simplified classification of epilepsy, I'm sorry for the headache experts, but what you usually see in clinical practice, what you see is mainly migraine headaches or tension headaches. So this is the way we evaluate patients with epilepsy coming to their clinic with the comorbidity of headache. Migraine and epilepsy. Migraine and epilepsy, they share a number of clinical attributes, including pathophysiology and clinical expression. Both are paroxysmal disorders. They constitute episodic disorders. They can be chronic, recurrent, and epileptic seizures obviously can be mistaken for a migraine on the opposite. So you're very careful about the history, take a thorough history and a proper evaluation to decide whether this is a seizure or this is a migraine attack. Migraine and poorly controlled epilepsy. It has been suggested that when you get that patients with epilepsy, with migraine, are more likely to have a poor epilepsy prognosis compared if you have patients with epilepsy without migraine. And the comorbid association between migraine and epilepsy has therapeutic implications, so obviously we choose the right anti-epileptic drug to control both the seizures and the comorbidities, for example, like the headache. How does the link goes? They are both, you have two problems. We have the cortex spreading depression and they have the synchronization. So the cortex spreading depression lowers the trigger threshold in epileptic focus, and that explains the onset of the pre-ictal headaches. Similarly, recurrent seizures may predispose a patient to cortex spreading depression, inducing a post-ictal headache. By analogy to the migraine patients, the stressful effect of the seizure itself is a trigger for a headache attack in subjects with migraine or interictal tension headache. So this is how it's a clinical way of thinking how the interplay between the migraine and the headaches and the seizures. If you look at the age of onset and the etiologies in the epilepsy patients, mostly we see patients around the teenage group, okay? And this is whether it's an idiopathic or it's a symptomatic or it's a cryptogenic. And then it plateaus, and then again in the elderly it increases again. So I was wondering if you see migraine patients, whether the peak age of onset is during the teenagers, children, teenagers, and later on. So according to the CDC center, the headache migraine is present in 16% If you have epilepsy or active seizures, the prevalence increases to 35%. So when you have seizures, you're more prone to having migraine. The other thing which is important, the age of onset of epilepsy was lower in patients with seizure-related headaches than those without. So the younger, you find more headaches with the younger age of onset, and the risk of occurrence of seizure-related headaches was significantly greater in patients with longer epilepsy duration. So in other words, when you have a long history of active epilepsy, or probably your headaches are getting worse, so it's a sort of a progressive, whether you're related to the seizures or the migraine. So it tells you it's not a static process. The headaches are continuing and the epilepsy is continuing. EEG, the big problem. The EEG, unfortunately, I'm not saying most, but frequently encounter patients diagnosed as epilepsy simply because they have something on the EEG. Okay? So this is more, you see it more in the pediatric population compared to the adult population. And nowadays it has been changing. We don't do the routine recordings. You do 2 hours and 3 hours. So you might encounter abnormalities. And you should be very cautious about interpretation before before denoting the patient is epilepsy. And obviously, it differs whether the patient is awake or asleep. So this is the first EEG. Any doubts about the diagnosis in case of epilepsy? Who would raise his hand for an epilepsy diagnosis? Definitely it's not a clear EEG. It's not a normal EEG. But what's the diagnosis? Spot diagnosis. Who would go for epilepsy? So this is, okay. Well, this is not an epilepsy case. It's a 10-year-old girl with benign childhood vertigo. It's an age-related phenomenon or symptoms, and they outgrow both on the level of the EEG and the vertigo. So you don't diagnose by the EEG. Another abnormal EEG diagnosis, epilepsy. Still, this is a normal variant. And I won't go into depth about the normal variants. But you have to be very cautious before interpreting the EEG as abnormal. Again, seizures, epilepsy, EEG, and still this is what you see on patients with migraine or even in the normal population. So it's important in the childhood or the pediatric age group, you have to rule out the benign paroxysmal vertigo of childhood, the abdominal migraine, cyclic vomiting, acute confusion migraine, paroxysmal torticollis, and the infant colic. And this is very important, and you see them frequently in the clinical practice. And if you compare to this, sometimes, generally speaking, when you have a misdiagnosis of seizures with migraine in childhood, okay, but in the elderly, most migraine patients are confused more with a vascular phenomenon. So children are in fact more likely to have autonomic symptomatology attacks with long-lasting ictal autonomic manifestations, while adults often have other sensory or motor ictal signs. So this is important to take into account. Children often they are misleading, and you can misdiagnose them as epilepsy, especially if you have an abnormal EEG. So this is another EEG. What's the diagnosis? This is a child with benign Rolandic seizures, nocturnal seizures. The question, other comorbidities, long-term prognosis, he will outgrow the seizures, will he get headaches afterwards? This is one of the questions we think about. Another EEG, posterior or occipital sharp waves, benign occipital epilepsy. Will he outgrow the seizures? Will he get migraine later on? Are they more prone to having migraine compared to the other children? So this is a paper, do children with benign Rolandic epilepsy have a higher prevalence of migraine than those with other partial epilepsies? Conclusion, prevalence of migraine ranges from 3% between the 3 and 8 years. Obviously, you go teenager, 19%. Gender ratio is similar before puberty and significantly higher numbers for girls affected after puberty. The incidence of migraine may be increased in children with BRE, and looking at different epilepsy syndromes, in the BRE 62% compared to 34% in absence seizures and 8% with partial epilepsy, 6% with history of head trauma. So benign, according to this study, benign Rolandic seizures are more prone to getting migraines. Other study contradicting Cleveland Clinic suggesting children with migraine are more likely to show benign focal epileptiform discharges. And there's a difference between benign focal epileptiform discharges and epilepsy. Okay? So it's not frequently, but sometimes you see benign epileptiform discharges in migraine in children with migraine. However, none of these children studied had clinical seizures. Migraine tended to be more common in children with epilepsy compared to those without seizures. The prevalence did not differ whether you have benign Rolandic seizures or benign seizures versus other cryptogenic symptomatic seizures. The terminology, we look at about 2 seizures, headaches between 2 epileptic attacks. This is what we call interictal headaches. Headache occurs in temporal proximity to the seizure manifestations we call periictal headaches. Headache and epilepsy, prevalence and clinical features. They looked at adults with epilepsy. 50% had 50% had seizures, okay, between migraine and between tension headaches. Migraine, most frequent type of headache, occurring in 26%, 19% with tension headaches. And what was, I think, was interesting, patients with only interictal migraine appear to be very prone to present a migraine attack before the seizure. So one of the problems we have with epilepsy or seizures, if you get a warning. So this sounds a bit interesting, maybe a prolonged, if he gets a migraine, he'll get a seizure, so he might, it has to be further studies, but it's a way of thinking how to predict the patient is going to have a seizure. This is the clinical conditions with epilepsy and migraine may coexist. The familial hemiplegic migraine, of course, people has to go into genetics. So the conclusions are, the comorbidity of migraine epilepsy is well known. Epilepsy, prevalence of epilepsy in the migraine population is higher than the general population. Headache as the only manifestation of a seizure is very rare. There's nothing called epileptic headache as a sole manifestation. It has to be accompanied by other manifestations. Seizures associated with migraine-like manifestations probably represent an epileptic event rather than episode of migraine and epilepsy. Some seizures get with a migraine-like manifestations. This is a genuine seizure. It's not a migraine attack. Association between headache and epilepsy commonly occurs all types of epilepsy and not just in occipital lobe seizures. The altered cerebral cortex excitability may be the link between the 2 conditions, and photosensitivity shows it. Thank you. Just there's a slide. We have the slide. Yeah, this is just to remind you of. We have on November 1st the Magnum's course with the European Neuroradiology Society. It's on the 1st and the 2nd of November on the multiple sclerosis.
Thank you, Professor Hassan. And let me ask you a very simple question. Do you ask as a routine an EEG for your migrainous patients? And if you find the subclinical EEG abnormalities in such migrainous patients, is it reflected in your plan for management?
No, I don't usually ask for an EEG for the headache migraine in children. In children, it's a bit different because in children sometimes it's misleading. But for the adult population, usually I don't ask for an EEG.
We will move to Calixte Court from Cameroon, Associate Professor of Neurology, Yaoundé University. He will talk about the clinical diagnosis of headache, a sub-Saharan African approach.
Okay, good afternoon. We all know that headache disorders, especially migraine and tension type headache, are really lifelong illnesses, and they are really prevalent throughout the world. And they usually affect people of all geographical areas, races, ages, and from all income levels. Despite this, we know that headache is really underestimated and remain under-recognized and undertreated in many sub-Saharan African countries. But we know that headache is also a sub-Saharan African problem. We've seen in the study done in Zambia, in a 1 year prevalence of migraine was almost 22.9%, 22.8% for tension type headache, and there was in the study a loss of 1.93% GDP due to headache. And in another study done in Ethiopia, the first one was in Zambia, the headache prevalence was 44.9%. With 49.9% for male patient, adult patient, and 37.7% for male. And in this same study, 1 year prevalence of migraine was like 17.7%, and that of tension type headache, 20.6%. And there was a significant, in this study, significant suffering and economic loss due to headache. In this publication by Tekel Amanot, we can see the many varied prevalence of migraine, really high on focal population like medical students till 88%, in urban dwellers 51%, and around 20% of the population in rural settings. In a study done in Yaoundé, Cameroon in 2007, the hospital prevalence of primary headache, tension type headache and migraine was 33.5%. And headache was the first presenting complaint in 12 months at outpatient consultation, 65.2% suffering from tension type headache and 13% from migraine headache. And 6% had both tension type and migraine headache. Secondary headache was 15%. In another study done in Cameroon, we saw that the first complaint on headache, on outpatient consultation on headache, and the first leading disease was headache. The main challenge in sub-Saharan Africa, first of all, is a limited physician training. In Cameroon, we have 21 neurologists for 22 million inhabitants. We have limited access to care. Headache specialists are only in cities. We have inappropriate or incomplete treatment, and there is underestimation of the morbidity of headache. The approach of headache in sub-Saharan Africa, I'll present it in 4 steps. The first one is to rule out potentially dangerous or secondary headache, a thorough history and physical examination, diagnosis of headache type, and the last one is implementation of the treatment. To rule out the potentially dangerous headache is really what we call the red flags. When we have a first or worse headache attack, progressive headache or newly daily persistent headache attack, when you have a headache on a patient of more than 60 or less than 5 years old, when the headache is associated with fever, with rash, with neck stiffness, when the headache is associated with loss of consciousness or abnormal physical examination, when there is associated nausea, vomiting, seizures, when there are comorbidities like immunodepression, HIV, or pregnancy, or when the headache occurs mainly on awakening. These are red flags that should be make us think about secondary headache and do brain imaging. The second step is the thorough history and physical examination. In the history, the main question we need to ask is about the area of headache involved, unilateral, bilateral, the quality of pain, pressure, hitting, beating, the pain severity that can be evaluated based on impacts of headache on daily activities, triggers, timing like morning, night, and pre-headache warning symptoms. We need to, in the history, to look about comorbidities like high blood pressure. That is, in Cameroon, 1/3 adult population have high blood pressure. We looked about head or cervical trauma, immune depression. I've talked about that. We need to look about past medical history of migraine or chronic headache or other conditions like diabetes, inflammation, anxiety, depression, and so on. And on physical examination, we really need to take the BP of the patients, the temperature, check for Glasgow Coma scale if there is loss of consciousness, and mainly look about meningeal sign, neck stiffness, Brzezinski or Kenny sign, and check about focal neurologic deficit, pyramidal sign, sign of raised intracranial pressure, sensory, vestibular, and so on. And the last one is to have diagnosis type of headache. When there is headache associated with fever in sub-Saharan Africa, the main diagnostic we think about is malaria. It's usually associated headache with sweats, chills, fever, muscle pain. Sometimes we have severe malaria with confusion, coma, and usually we do malaria antigen test, and the treatment is based mainly on artemether or quinine. Headache with fever, the second diagnostic frequent in sub-Saharan Africa is meningitis. And in this case, we need to do lumbar puncture with or without CT scan and then put the patient on antibiotics. The primary headache, more frequent in Cameroon, are tension type headache. And in this study that we done in Cameroon, we have a comparative characteristic of tension type and migraine headache who are more frequent in Cameroon, like episodic tension type headache in 63%, location more bilateral on tension type than migraine who is unilateral. The type is more non-pulsating on tension type on pulsating in migraine headache. And aggravating factors usually are mainly physical activity, phonophobia, and we have other accompanying symptoms. The approach to the diagnosis of headache, when we have headache of sudden onset, the first thing to think about is subarachnoid hemorrhage, as we know. And when we have sudden onset headache with focal neurological deficit, we need to think about stroke, ischemic or hemorrhagic stroke. And when we have third cranial nerve palsy, we think about ruptured aneurysm. When we have recent onset and gradual increasing headache, we think about raised intracranial pressure with brain abscess, with tumor, and sometimes neurocysticercosis. When we have gradual onset headache or chronic with same topography, same location, usually we think about arteriovenous malformation, sometimes meningioma. When there is a headache on elderly patient, we mainly think about Houston disease, and we have other extraneurological headache like due to drugs, toxic, acute BP, and so on. And to conclude, I would say that headache is the main complaint in outpatient consultation in many sub-Saharan countries, as we know. And there are many etiologies that we've gone through, and the diagnosis is mainly based on history, physical examination, and rarely biology, brain imaging, based on characteristics of headache accompanying sign and symptom, comorbidity, and past medical history. Thank you.
Any question? Thank you very much.
Lastly, Professor Lala Sek from Senegal will speak about the impact of migraine.
Thank you very much. I will first apologize the organizing committee for allowing me to do this speech about migraine impact. I will also apologize for my English as I'm French speaking, but I do my best to speak well. What about migraine impact? We'll, after introduction, see the problem, then speak about the impact, and then how to try to manage this before concluding. Migraine is a very common disease, interesting 10% of the population, and has a very wide impact on their daily life. One of the major factors impacting their daily life is in the pain, but we will see that it's not the only factor. So all practitioners will have to seek for these factors, but the first stage is to know what about this impact. The problem is that this disease is concerning people of young age. This means workers, and it's a very debilitating disease. So it's known that practitioners and patients, and even not migraine sufferers, recognize there is a large impact in all domains of the patient's daily life. If we compare migraine to other chronic disease, it is seen that except the physical conditions and health perceptions, all domains are very low in migraine disease. So if we can do a good positive diagnosis, a good differential diagnosis because of IHS criteria are well known, we can most of the time give the good medication to the patients. But what we often forget to do is to assess the impact of migraine in the patient's daily life. This is very wrong because this impact has a great impact itself on the management and has to be done even before any treatment. All patients must have an assessment of the impact of his migraine before being treated. Who is impacted? We know that it is individuals themselves, above all those with severe migraine, the family members also, but society and economy. This impact is concerning the fits, because during the fits they have pain, but also accompanying symptoms that can sometimes more impact in the physical conditions. But also out of the fits, we can see that some behavior, some bad behaviors regarding coping can also lead to bad quality of life condition. Regarding individuals, we can see that people with severe fits can have great emotional consequences, and this prevents them from carrying correctly their task. And we can see that sometimes a whole week can be lost because of avoidance behaviors. Some studies like that carried by the Club Migraine Encephaly in France show that some migraineurs' emotional impact was due to the fact that family didn't show enough support during the fits. On the physical side, in a French population study suffering from a severe migraine, 13 days were lost per month, and this due to the accompanying symptoms like nausea, photophobia, and visual disturbance. This had sometimes some very bad physical consequences as sleep disturbance. On the familial level, we can see that some research shows that people are sometimes stigmatized by the family members, while the non-suffer migrants can't realize this kind of stigmatization. This most of the time lead to some consideration like migraineurs are considered as lazy people, as not serious and not aware people, and they are most of the time unable to manage conditions. Another work has shown that one of the impact of the family is that they have to modify their activity schedules due to the fit. For example, 14% of patients had to modify their work program, and some had to be helped by relatives. On the familial side, another study showed that there were problems in relationships between the migrant sufferers and their family, particularly the partners, as they were unable to stay with their partner during fit. They were unable to be with their children and to keep on doing their family's leisure activities. And this led to guiltiness and to guiltiness feeling and to difficulties in their relations with family members. And we can see that also children had to lose some familial activities like leisures and others. Regarding school and educations, this same study had shown that several migrants led to difficulties in patients, and sometimes they had to drop out from the professional career. In a study done in Brazil in some children, many factors had an impact on the school performance, like having migrants very frequently, like having long-lasting migrants, like having very intense and severe migrants, and sometimes the accompanying symptoms. Regarding professional impact, we can see that this study shown in this French population that most migrants were aware that they had a real impact on their professional life, as it decreased their work efficacy. They had sometimes to decrease the time, the work hours in order to cope with their migrant, and they were stigmatized in the workplace. The whole year absenteeism was 33 days. This was also seen in many other studies, like the Shares America. There was a very large off work time, and sometimes even if they were in the workplace, the working time was significantly reduced. On the economic side, we can see that there are some direct and indirect costs due to the consultations, but also medication drugs, and sometimes to emergency case or admission or cost due to admissions. Sometimes they have to do medical analysis, and also we have seen that work loss will lead to salary loss. Direct costs sometimes reach some hundreds millions, and even if we exclude auto medications, we can see that even if they stay at the workplace, migrant sufferer has a reduced efficiency on work because working with, it's over? 1 minute. Yes. And the World Health Organization saw that migraine was among the 20 most societal impacting disease, and this is emphasized when we consider only female gender. This impact is also is increased if the migraine is transformed in chronic daily headache. Management is to first do an important assessment of impact before treating, keep a diary, do an assessment regarding disability and quality of life, and also facilitating factor of the impact and communicate a lot with the family. We can use some scales like headache impact test, like migraine disability assessment questionnaire, and also some scales regarding quality of life. I was in the conclusion to say that impact is important to assess in migrant sufferer. It's a major factor of failure of the treatment. All domains has to be seen, and first do a clear diagnosis and do a clear assessment of impact before treating any migrant sufferer. Thank you for your attention.
Okay, thank you. So we came to the end of the session, and may I call for the chairperson for the next session, Professor Azza Abbas. Session. It's time for lunch? Okay. Okay, thank you. Thank you for attendance. And now the time for lunch. Okay.